This podcast is sponsored by Zeiss Professional Education.
Hello, and welcome to GT, the podcast. My name is Danica Marrelli, and I'm a clinical professor at the University of Houston College of Optometry. Today, I'm joined by Dr. Anu Laul, who's an associate clinical professor at SUNY College of Optometry in New York City. Welcome, Anu.
Thank you for having me.
So today, we're going to talk about testing glaucoma patients in the first part of our podcast, what tests are important in diagnosing glaucoma. And then later on in the episode, we'll move in a little bit more to treating them and kind of watching glaucoma over the long haul. So Anu, I'm going to start with you and ask you, if you had to choose your must-haves in terms of tests that you want for a patient who comes to you for a glaucoma evaluation, what does that look like?
Yeah, I mean, that's a great question. So there are certain things that I have to have in regards to practicing glaucoma at a high level. So the first thing that I would say, obviously, is Goldman tonometry. You want to make sure that you're taking an accurate eye pressure reading, something that is repeatable, for one, and something that can give you, obviously, a good eye pressure reading. Secondly, things like gonioscopy. I think gonioscopy is very, very important. You cannot diagnose the type of glaucoma without doing gonioscopy. You'd be surprised to see how many times patients are presenting with so-called primary open-angle glaucoma, but by doing gonioscopy, we can see that they might be, some angle recession or pseudoexfoliation, pigment dispersion, or even sort of plateau iris configuration that's often missed. So gonioscopy is super, super important. Other things that are important to me as part of my initial glaucoma workup is a baseline visual field and a baseline OCT. Now, a baseline visual field is necessary, particularly because that's how we grade glaucoma. So how do we stage our glaucoma patients? Well, we use a visual field. It's a functional test. The OCT, of course, is very, very helpful, particularly in early glaucoma, due to the fact that it has a very high sensitivity when it comes to optic neuropathies in general. So to pick out normal versus abnormal, super, super high. And then pachymetry. We have a lot of good data that shows us that pachymetry is a risk factor as well. So on my first visit, that's essentially what I do, and an undilated nerve examination. I usually have the patient back for additional testing, and a dilated examination and photography to look at the nerve as well. I think we underutilize photography in our glaucoma practices, and the studies, CMS studies show that, where we're taking less photographs, but I think photographs are very, very helpful. It gives you a lot of useful information, particularly following patients long term.
Yeah, it sounds like your workup is pretty similar to mine. Of course, I'm going to check their pressure every single time, Goldman tonometry being the sort of the gold standard. Pachymetry once, let's see if our Goldman is over or underestimating their true IOP based on corneal thickness. Gonioscopy is so important, and sometimes I'll actually sort of save it for a little bit later. If I want a really clear cornea for good photography or good OCT, I might do it at a follow-up visit, but it absolutely has to be done. I want to dig in a little bit into visual fields and OCT, but one other thing that struck me as you were talking about your evaluation is that I think that with technology that we have, which we love and which is really important, in some cases, I think we relegate our clinical exam of the optic nerve to an afterthought. And I think it's really important to remember that the most important tool we have in making the diagnosis of glaucoma is our brain and our clinical exam of the nerve and looking for those characteristic structural changes. And then we can quantify those with an OCT. And certainly our OCTs can see things that we can't, or at least that I can't clinically. But I think it's really important to get a good look at that nerve. But I want to dig in a little bit to visual field. So I also run a visual field on first-time glaucoma suspects or patients that, have frank glaucoma, because it is the only real way that we can measure their functional impairment. But there are a lot of different choices when we're looking at visual fields. So what's your go-to standard glaucoma test strategy? Are you using 24-2 or 30-2? Are you running any 10-2s in early glaucoma? What's your take there?
Yeah, that's a great question. So I'm going to get a 24-2 early on. It's one of these things that in most of my glaucoma patients, or I'm monitoring patients for glaucoma, during the first 2 years, 2.5 years, I'm likely going to get somewhere between 5 and 6 visual fields. Now, visual fields may not be the most fun test for patients to take, but we know that there's a lot of variability in it, and patients do get better as they take it. So there is a learning curve. So I sometimes need to throw away maybe the first or another visual field here and there. But I still want to be able to get a good analysis of the patient. I know we're going to be talking about longitudinal data in the second half of the podcast, but I want to get some really good data initially. In terms of, CETA standard versus CETA fast or CETA faster or 24-2Cs, I usually do, I kind of shifted towards CETA fast right now. And that's based on some of the work by David Crabb when he looked at time to detect. So in his study, he was comparing CETA standard to CETA fast and looking at mild glaucoma, moderate glaucoma, and severe glaucoma, and high rates of progression. So let's say, 2 decibels per year versus 1 decibel per year versus a half a decibel per year. And when you look at time to detect progression, it was relatively equal between those two types of field analysis. So I do feel a little bit more comfortable using, the CETA fast algorithm. Do I run 10-2s and or 24-2Cs? I like the 10-2. It's one of these things that at some point I'm likely going to do a 10-2 on my patient, particularly if I notice loss in that inferior temporal region, where most people call it that macular vulnerability zone on the RNFL scan, or changes to the ganglion cell scan. So, it's more pointed towards patients that I feel would need it. And of course, if there are any central points missing on the 24-2, then yes, absolutely, I'm going to rush and do a 10-2 relatively soon. That might be a month or two out.
Yeah, I think when we started to understand a lot of the work that Don Hood has done, looking at the macular damage in early glaucoma, and this idea that, the 10-2 might become important in early glaucoma. I'll be honest, my first thought was like, I don't want to have to do another set of visual fields. What are we doing here? And so I've stayed pretty comfortable doing a 24-2 as my initial test. But if that 24-2 looks normal and the patient shows some loss on their ganglion cell that looks characteristic of glaucoma, I know that there's a chance I'm missing some visual field loss. So that's the patient that I'll then take and run the 10-2 on. Moving into OCTs, though, we kind of let the cat out of the bag here a little bit, but I'm a little surprised when I go around the country and I talk to people about glaucoma, how many people are not doing the macular scans that are specific for glaucoma on their OCT. And I think it's a really powerful tool in looking for glaucoma. We think about optic nerve, retinal nerve fiber layer, but we have really compelling evidence. And it's actually part of the American Academy of Ophthalmology preferred practice patterns now that we do the macular ganglion cell or ganglion cell interplexiform layer scans in those early glaucoma patients and glaucoma suspects.
Yeah, I totally agree. I'm right there with you. So in our second half of the podcast, we need to take a quick break at the moment, but we're talking about long-term patient tracking and analysis. So stay tuned.
This podcast is sponsored by Zeiss Professional Education.
And welcome back, and thank you for sticking with us. So Danica, I had a couple questions here for you. So on your patients who do have glaucoma, some patients that you are treating, as you're thinking of the long game, how do you detect progression? How do you define progression in your patients? And what type of technology do you use, as part of your longitudinal data?
Yeah, I think first of all, I would say that it's always important to think about glaucoma as a marathon rather than a sprint. And I think we can kind of get into a situation where we get these knee-jerk reactions. Oh, this visual field looks like it maybe got worse. And there's always time in glaucoma to kind of take a step back and rethink it. But in terms of what I'm utilizing for following patients over time, every single time the patient's coming in, I'm getting an IOP reading. But I think it's important to remember that that's not what is going to tell me if the patient's glaucoma is progressing. That just tells me if I'm meeting the target pressure that I've set, hoping that that's going to be the place where I can stabilize their glaucoma. So I tend to set up my follow-up visits in terms of structure visits and function visits. So on structure visits, I tend to dilate the patient. I'll run an OCT, both the RNFL and the ganglion cell analysis of the macula. And then I'll do function visits where my patients don't have to get dilated, and I'll do visual fields on those visits. You sort of alluded earlier in the beginning of the podcast about getting 5 or 6 visual fields in the first couple of years. And I think that sounds like so many visual fields, but it's really not. And we have good evidence that we need probably at least that many to be able to detect progression in a reasonable time frame. We don't want to do 1 visual field a year and then decide, it takes us 6 years before we can, determine that this patient is progressing. And similarly with OCTs, although they are more reproducible than visual fields, there's still some variability from test to test. So in terms of the tools that I'm using, I'm almost never looking at a single field analysis anymore or a single OCT report. I'm going straight to the guided progression analysis and looking for that statistical power. How do glaucoma patients change over time? Looking at today's visual field, not just related to the last one, but related to every visual field they've ever taken. And I find for me, the easiest way to look at this is within Forum, a data management system. You can go into Glaucoma Workplace. And I actually was just looking at I was doing charts this afternoon, and I was looking at a patient and thinking, it's amazing that I can click into one box and see their visual field progression. I can see their OCT progression or stability. Don't forget that, we're looking for progression, but there's comfort in seeing stability over time. So those are the things that I'm using on a regular basis.
Yeah, absolutely. Gone are the days of printing out visual fields and holding them side by side by side.
Oh yeah, it looked like a
we
Dead
once
Sea
did.
Scroll.
Right.
They roll out. It's got 20 feet of visual field paper.
Right. No, that's that. You know what? That's exactly it. And with you mentioned the technology, particularly looking at rates of progression. And I want to get an idea how you look at things. I mean, I can tell you how I do it in terms of a high rate of progression, where I'm very concerned about a patient. They may have like a 2 decibel loss per year. Moderate will probably be around 1 decibel per year loss. And then I like to keep my patients in the ballpark of less than a half of a decibel loss per year on a visual field. And the beauty of using a data management system like Forum, you can pull that immediately. You can actually see how your patients are progressing. Do you use something similar, or numbers about the same?
I do. And, one of the things, not to just harp on Glaucoma Workplace, but it's so amazing that in the progression analysis for the visual fields, you can not only track mean deviation over time, you can track the mean deviation of the superior hemifield over time. So, you can have a patient who has a pretty normal or a pretty horrible inferior field, and you're really concerned about the superior field, and you can, narrow it down to that. I do look at those trends. I think rates of change are super important in the long term, but certainly in those early first couple of years, we're looking at event analysis too, and looking at, are there points in this visual field that are changing in a statistically significant way? And it's not just about that. It's not just about how many triangles do you see on your plot, but, are they all in the same location? We know that visual field defects tend to worsen by deepening and by enlarging, and much less frequently by a completely new part of the visual field becoming damaged. So I think that there's some sophistication of looking at event analysis, because you might get 3 triangles and a little message that says possible or likely progression. But if those spots are, very far away from each other or far away from the existing scotoma or depression, it's less likely that that's real change.
Absolutely. The other thing I wanted to mention as well, I mean, for example, once you start an intervention or you up your therapy, you can actually look at, hey, this is where I started my therapy, and now I'm looking at longitudinal data since that intervention. So, the slope initially might look very steep as things are changing, but after your intervention, things look a little bit more stabilized, which also makes you feel a whole lot better.
Yeah, I think it's important that when you make a major change in your patient, so let's say that you had a patient who you set an initial target pressure of, mid-teens, and that patient showed unacceptable progression while meeting that that target pressure. You're going to have to reset that target pressure to something lower, and you're going to have to do something to get there, right? And so once you achieve that new target pressure, you really need to go back and reset those baselines. And it's really kind of like the game starts again. And one of the things I think is really important is that you then have to repeat those tests a little more frequently, just like you did in the very beginning. So whenever you're making a major change in these glaucoma patients' therapy, you're sort of starting the clock all over again. And I think a lot of people forget that.
Yeah, and I think it's a great point just because the other thing I harp on my students about, of course, is thinking about a target pressure. I think that's so important. And knowing that it's a moving target in terms of the fact that if my patient is, I set a target at 15, their IOPs are consistently at 18, much better than maybe their 25, 26 initially, yet they haven't changed, I put my target up to 18. Conversely, just like you said, if a patient is progressing, you may need to rethink, your target eye pressure. So again, I think setting goals is so important, and it also gives the patient something to maybe look forward to as well.
Yeah, and I think one of the things we hadn't really talked about how we educate our patients or talk to our patients about what their testing tells us. But I think that with GPA and being able to see, especially trends, everybody can understand the concept of a flat line or a line that is decreasing over time. And you can show a patient, I'll often bring up my own visual field and say, look, my visual field is stable, so the line is flat. And then I might show them theirs and say, you can see in your right eye, your line is flat, but in your left eye, we have a downward trend. And we want to change that. We want to make it look a little bit more like your right eye, that kind of thing. And being able to, pull it up on a screen and show it to them. And I think that's something that anybody can understand and can be, maybe a motivating factor for our patients to stay adherent to their medical therapy.
No, I totally agree. One of the things that you have to consider as well is that in a lot of cases, patients don't feel glaucoma, and you're putting drops in that irritate their eyes. So they're like, why am I taking this medication? So to get buy-in from the patient, showing a screen like Forum, for example, and looking at trends over time, help you get buy-in from the patient.
Okay, I think that unfortunately our time is up.
It's always too short.
I know this was really fun. I could talk about glaucoma forever, and who knows, maybe they'll have us back for a second podcast where we can dig a little bit deeper. But Anu, it was great chatting with you.
Great to chat with you as well.
Thanks to our listeners.
Great, thank you.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.